Okay, so this is an update on tonsils and adenoids, and we're going to go over essentially all of the guidelines that are out there from the American Academy of Otolaryngology, the AAP, and the American Academy of Sleep Medicine. As it turns out, the new AAO guidelines are due this fall by now, but as of 2 days ago, they weren't there. So we're also going to review the literature that they're using to make changes. So our objectives are to briefly go over the anatomy and physiology of the tonsils. We'll review the diseases of the tonsils and adenoids that result in someone sending them to someone like me to have consider removal, and then go over the clinical practice guidelines, and also go review the reasons that aren't necessarily in the guidelines but still may help. So obviously, anyone who does primary care knows this is relevant. 15 million people a year seek a visit for a sore throat. 500,000 tonsillectomies are performed in the US. About 15% of all outpatient surgery are tonsillectomies. And in children, sleep disturbance and recurrent pharyngitis are by far the most common reasons we'll do this. So if you're going to skip the rest of the talk, if you get this slide, you've got most of it. And you'll see this again. First, tonsil infections don't have to be strep to potentially benefit. Second, infections before we really start thinking about taking out tonsils, independent of mitigating factors, are 7 for a year, 5 for 2 years, 3 for 3 years. All clinical practice guidelines agree that tonsil and adenoid removal is first-line therapy for sleep apnea in children. And then the contributing factors we'll go through at the end. And then I put shared decision-making is important, especially when it's easy to follow guidelines. You don't need me for guidelines. It's the question of when we haven't quite met the guidelines, who's going to benefit? And in that situation, the parent really has to know that what risk they're taking and what potential benefit they're going to get. So, brief review of the anatomy. They're part of the mucosally associated lymphoid system. They're most active 3 to 10 years of age. So if you look at most adults, you may not be able to see their tonsils, or they're quite small. They're non-keratinizing squamous epithelium. They have deep crypts, and then there's a breakdown of the basement membrane in those deep crypts where you can get a transportation of antigens for recognition of the, education of the immune system. Antigens are taken up. They can either stimulate memory cells to target it later, or can form plasma cells that will create an IgA or other antibody production. Chronic or recurrent tonsillitis interferes with the antigen education. So when parents always want to know, what am I doing to the immune system if I take out the tonsils? The answer is, by the time you're talking to me about taking your tonsils out, that ship has sailed. Tonsillar sizing, this is out of the AAO guidelines. They 25%, 50%, 75%. A lot of times notes will come through 1, 2, 3, 4 plus. Basically, size doesn't have as much to do with it as you think. It's, are they having symptoms? But for me, if they're touching, they're 4. If they're touching, they're 3. If they're less than that, they're 2. And then everything else is 1. So guidelines we're going through, you can look at those in your packet. But these are the available guidelines from the major players. So first thing out of the clinical practice guideline is very simple, but it's the definition of a sore throat. People will come in saying, I've had sore throats, but I haven't had this many strep. And although strep is important for reasons we all know with respect to what it can do from a systemic standpoint, it doesn't have to be strep to be a sore throat. If you have a fever along with cervical adenopathy with big tonsils, that counts. And that means that although we don't want to take everybody's tonsils out, if this is a recurring theme but still strep negative, they may benefit. For example, the picture on the right, you'd say, well, this is more likely mono or some viral issue than strep. This is a busy slide, but it's in your packet. This is out of the AAO guidelines. Essentially reviews the 7 for 1, 5 for 2, 3 for 3. The most important take-home point is the middle of it, which is when we get a tonsillitis, as long as they have a sore throat with either, but not all of, a fever, lymph nodes, or exudate, it counts. And we can believe people as opposed to making them come in 8 times, meaning they recommend that if you've only seen them once and we don't have the data, well, let's see them at least twice and maybe convince them to push out a year, because about 25% of people will fall out of the guidelines in the first year. But we don't have to have every single thing documented. For example, when I see people in the office, I'm very interested in looking at records if they have them, but since very few people are tackling me to take their tonsils out, when they're not having a problem, you assume that they're not lying, hopefully. So, little review of the previous slide, which is if it's less than 7 in a year, we really tend to push them off unless they have mitigating factors. Multiple days of school lost, abscesses, hospitalization, airway obstruction. Specifically, again, because people will fall out of criteria given time. And we're working on the air conditioning back there, it looks like, so stay tuned. Move into the second most common reason for taking out tonsils. Sleep disordered breathing, which is abnormalities or respiratory patterns that change sleep quality, most commonly diagnosed by a sleep study. I was looking for a picture of a bulldog and didn't have one, so these are my dogs who don't have sleep apnea, but do have the daytime symptoms, which are excessive sleepiness, hyperactivity, and poor concentration. So maybe they need a study. So sleep disturbance is a big deal. It affects quality of life significantly. When they do studies and look at kids who have significant sleep disordered breathing, they utilize healthcare more. They use more antibiotics. That's not just for tonsils, that's in general, meaning they're sicker kids. And 30 to 40% of kids who have diagnosed sleep apnea will have hyperactivity, behavioral issues, more missed school, decreased performance, increased bedwetting. So this is out of the guidelines as well. You can review this on your own time, but this is a slide that essentially goes over the limitations of tonsils for sleep apnea. As we'll see in a few slides, tonsillectomy and adenoidectomy in a healthy kid with giant tonsils works really well, even though they don't like us for a few days. If you have an obese child or a child with other, we've shifted them more into an adult phase of sleep apnea. And as most people may know, surgery for sleep apnea in adults does not work very well. And this just reminds us that when we have that obese child or that child with a congenital craniofacial issue, we really need to take a pause because we may not be helping them as much and they're at higher risk for the surgery. So this is the AAP guideline for sleep apnea. Once again, adenotonsillectomy is first-line treatment. One of the guidelines is you can use CPAP. Surprisingly, some kids will tolerate CPAP. I haven't met any of them yet, but there are places that will try and fit them. In my experience, you have to have really bad sleep apnea to the point where your child is almost somnolent before CPAP will make a huge difference, but that's just me. Obviously, weight loss if appropriate. AAP throws out topical nasal steroids as a possible treatment. This is just good to remember. Sometimes if you let someone breathe better through their nose or shrink their adenoids, they will sleep a little better. And the bottom line is, if you're educating a parent on sleep apnea or sleep disturbance, and you say, why don't you try Flonase for a few weeks, and they say that fixes the problem, that kid doesn't have a bad enough problem that they need a surgery. So, do you need a sleep study? I am not a fan of sleep studies, so that's my disclosure. In pediatrics and adults, you absolutely have to have them. 3 schools of thought. AAO says not if you have a good history, but you should get them with any obese child or someone with a craniofacial problem, Downs, etc. AAP kind of splits it and says either get a sleep study, screen everyone, either get a sleep study or send them to a specialist if the sleep study is not available. And not surprisingly, the American Academy of Sleep Medicine says everybody should have a sleep study. So what are you supposed to do? This is the practical approach. This is what I do. Children with neuromuscular problems, Downs, the default should be a sleep study. The only reason you should take somebody's tonsils and adenoids out without a sleep study, and even that's questionable, is if you have someone with Downs who's having recurrent strep tonsillitis and you are going to take the tonsils out for another reason anyway, you're not necessarily changing your trajectory. But other than that, they should all have them. Otherwise, healthy children. Because of the guidelines that are out there, I review it with the parents that it's an option. I offer to order it, but I also ask them, does your child have a severe enough problem that you would sign them up for a surgery? Because if they don't, what are you getting this? You're not going to do it. You're not going to do the treatment anyway. Number 2, will you believe the sleep study result if you get it? So sleep studies in children come back much more mild than in adults. And so if the study comes back and it says you don't have bad sleep apnea, but the parent says, well, then come over to my house and watch what happens every night, you're still going to offer their tonsil and adenoid. And the converse is true as well, meaning if the sleep study in one bad night, you're not necessarily going to take them off to take their tonsils and adenoids out if the parents say they really don't have this on a consistent basis. So more often than not, I don't order sleep studies in otherwise healthy children. Efficacy. Does it work? Yes. We'll see this in a study, but multiple studies show improved quality of life, improved school performance, increased growth, which is probably more related to eating, which we'll get to in a minute. So that's our practice guidelines. These are the 3 studies that they're looking at to update the guidelines in probably tomorrow, since this talk is today. But one is a study on tonsils. Basically, take-home point is that they saw significant improvements, but the study did not show that the benefits increased over time. So after a year, the efficacy trailed. The only problem is they didn't even follow the current guidelines. They were including studies that said take out tonsils after 3 infections in a year. So if anything, I would predict that it's going to shift towards a little bit more conservative, but otherwise probably won't change it. Second is a meta-analysis of sleep apnea. Essentially, this shows, yes, taking out the tonsils and adenoids of people with or children with a normal body mass index works for sleep apnea. You might occasionally have someone come in and say, can I have part of my tonsils out, or a partial tonsillectomy? I am not a fan, so I am biased against them, but there are studies that say that it works. Basically, the thought process is there's decreased pain and improved return to diet. A lot of times 2 to 4 days versus 4 to 6 days. When you look at the studies, it says that some of these people need their tonsils out again later, and they're more likely to have sore throats, but they get the same benefit from sleep disturbance or obstruction. If I'm having my tonsils out, one of my criteria is I'm not coming back, so I don't offer it. So this is actually the more interesting part of the talk because the guidelines most people are familiar with. So when you have those guidelines, what else do we have that we'll think about that will guide us or push us to take the tonsils out inside or outside of the guidelines? We're going to go through tonsil stones, we're going to go through orthodontic issues, we're going to go through peritonsillar abscess, behavioral, bedwetting, tonsil asymmetry, and I'm happy to answer questions on, but those are other indications that we frankly don't have time for today. So peritonsillar abscess. Fullness of the soft palate. I like this picture because a lot of times you get people that come in for a peritonsillar abscess and you see these giant mono-looking tonsils with florid exudate, and those people usually don't have an abscess. It's the people where their tonsils don't look that bad, but they have fullness, and their ear is clear, and they say their ear hurts. So if your throat looks like this, I always ask them, does your ear hurt? Because if your ear doesn't hurt, I'm putting you on antibiotics and steroids and seeing you back in a day or 2 and hoping for the best. If your ear hurts, I'm more likely to stick a needle in that. You can convince people, most people, 12 years and up to let you drain it in the office. They don't love it, but they get a very rapid improvement, and it's totally worth it. Under 12, that would be a very mature young individual. So if you end up having to drain an abscess, you have to do it in the OR. You don't have to take the tonsils out, but for me, if you're in the OR and you're that age, I'm taking them out when I drain the abscess. If you're an adult and you have 1 drainage, it's kind of like a strikeout issue, except for after 2 strikes. You can get your first abscess, won't take your tonsils out. If you get it again, you're done. Tonsil stones. So when I was doing this talk, I thought it was funny that the New York Times had a little piece on this a few years ago, so I put that in there. But basically, these are retained food or cellular debris that people get. If you start asking people, they're incredibly common, but they don't have to have treatment. Ultimately, if you have a bad enough problem that it's a social issue from halitosis standpoint, or that you're getting recurrent sore throats that aren't bad enough to go to the doctor for, and you're getting these several times weekly, we can fix it. But since it's a shape problem, meaning it's that the tonsils or crypts are trapping stuff, the only way to fix it reliably is to take out the tonsils, which hurts. So if someone uses a water pick or gargles and it works, more power to them. Usually it doesn't work that great, and it becomes is it bugging you enough that you want to do it? PFAPA, pretty rare but fun to say. So, these are young kids who get aphthous ulcers and also cervical adenopathy and fevers. They have to have a CBC because cyclic neutropenia can fool you. There are 2 studies out there that say that taking out the tonsils help, but also there's a significant amount of resolution with age. So this is something where ultimately it becomes the question that I say most commonly with parents: does your child have a bad enough problem that they need my help? Because if they don't, we can watch them. If they do, we're probably going to benefit. This one is fascinating, and you could talk for an hour on it, but sometimes the dentist will send them to you or to me saying they have big tonsils and adenoids, do something. They're probably right, but we don't have enough data to make great decisions. So the question that's really being asked is, does the mouth breathing associated with nasal obstruction and adenotonsillar hypertrophy affect the dental arch, facial growth, or orthodontics? And there are studies out there that imply that it does, but our ability to predict in any one child is poor. So I love it when they come in with this problem and have sleep apnea anyway, and I certainly ask for sleep apnea because that makes the decision easy. Otherwise, it's a pretty involved conversation with the parent saying, look, tonsillectomy has risks, so do you have a bad enough problem that we're going to go through this? If you asked me to predict, if we could run a longitudinal study 50 years out and make all the 3 to 5-year-olds breathe through their nose and not their mouth, you would probably see less sleep apnea in adults, but nobody's asked me to do the study. So for anyone who's not familiar, this is just a brief overview. What do they go through? Unless you're less than 3 years of age, it's an outpatient procedure. Kids go to sleep with a mask. It takes them about 30 seconds. There's no shots. IVs go in after they're already asleep. The procedure takes about 10 to 30 minutes. They spend an hour to 2 hours in recovery, and then they're home. And the first 2 days, they think everything's great, usually. And then days 3 to 7, they're calling you or me saying something's terrible. Sometimes they end up in the emergency room. When they get to the point that they're calling you and they're, for want of a better term, just stop drinking and they've started a cycle, it's amazing what a bag of IV fluids will do. And it's just not worth them going through the misery, even though they don't want to go to the ER. Once they're there, it's like, just get hydrated, restart the process. It's not even the pain control. Tonsillar fossa always look terrible in the first week to 10 days. So this is a picture of a tonsillar fossa probably 7 days out. No longer do we recommend antibiotics with tonsillectomy. So we're not giving them antibiotics at the time of surgery. That also means if someone's 7 days out from a tonsillectomy and has a fever to 102, they're getting antibiotics. How are you supposed to tell that's infected or not? So pain control in tonsils in the young kids and even in the older kids, we're moving away from narcotics. Nobody under 7 ever gets narcotics unless they're being monitored. And what they've actually found is that if you're aggressive with Tylenol and Motrin, those kids actually eat faster. So that's out there. I love steroids because they're good for what ails you, but they do help a lot with pain after tonsils. So it's something you can use. If you have someone post-tonsils and they're not eating, they're not drinking, and they're not on steroids, you can give them some Prelone, and 4 hours later, they'll be slightly happy. Complications. Let me see how I'm doing on time. Okay. The complications of tonsillectomy. This is important because it is a real surgery. So the 2 to 3% have bleeding. That means they're going to end up in the emergency room or even back in the operating room getting that stopped. We don't like it when it happens, but it's been 2 to 3% for 50 years. Velopharyngeal insufficiency. I've seen it once in my career. Residual or recurrent issues, almost never, unless you're doing partial tonsillectomies. And then the big thing is mortality. Nobody wants to talk about it, but it's there, and it always makes the news when it happens. Our data on it is bad. It is almost always in a high-risk patient, obese patient with sleep apnea, or in the age of narcotics, it was some of those rapid metabolizers. In the US, the data says 1 in 15,000 to 35,000 versus 4 in 2 million in Britain, where they looked at the National Health Service for 20 years. So it's somewhere between 1 in 15,000 to 1 in 500,000. The challenge with this is always how to talk about it. I usually end up talking about it as the hit by the bus phenomenon when I'm talking to parents, because it's our job to tell them that it's a risk, but you don't want to scare people. So anyway. And then back to the most important question with all of these is, does your child have a severe enough problem that she or he needs intervention? So summary, tonsil infections don't have to be strep. We've already went over the numbers. Tonsils and adenoid removal works for sleep apnea, but obese kids and kids with syndromes are a different presentation and require care. Other things that we can sometimes help with: halitosis with tonsil stones, dysphagia, peritonsillar abscess, and PFAPA. Let me see how. I'm only 9 minutes. Finally, in young kids, especially with sleep apnea, if you start to ask them, you will be surprised how many of these kids have dysphagia from their tonsils. And sometimes that, at least in my opinion, is why they gain weight. So when you have a kid who's a mouth breather and or snores, if you ask them, well, how do they eat? Most people say, great. Then you say, what do they like to eat? Do they like yogurt? Do they like drinks? Do they like noodles? They say yes. They say, how about chicken or steak? No, that's terrible. Well, people who can't breathe through their nose have to choose between eating and breathing. Everybody chooses breathing, and so if that history fits, we make a huge difference when we get them out. So I think that's all I have.